So I guess one of the key questions about substance misuse in late life is why are we bothering? Because basically the main areas of substance misuse decline with age. Alcohol, illicit drugs, tobacco, with one exception, of course, prescription drug misuse increases with age. So basically what we are responsible for, actually we encourage to happen in a way by the fact that we do the prescribing. So that's the raw data, but I guess there's a problem. The baby boomers, and I think a good proportion of the people in this room are part of that generation, I know I am, we've arrived in late life, and we're different. We're different to the older people that went before us. This is the baby boomer generation. You can tell by the red bit on that graph, and you can see the huge increase in numbers of births between 1946 and 1964. That's the baby boomer generation. So what characterises us? Well, we are quite different. In the 70s, 60s and 70s, we were nonconformist. Women's rights came to the fore. Drug experimentation was a big part. Well, you can remember in the 60s, those who were there in the 60s, well, as I say, you're there, you don't remember it much anyway, but in the 60s, drug experimentation started to come through, and particularly in popular music, as you might recall, Beatles, the Stones, and all those sort of groups. Environmental concerns were very much part of that generation, and a preference for rock and roll music. Rock and roll music has been a big part of this story. But then, as they got older, as this generation's got older, they become a little bit more conformist, more financially secure. Baby boomers have a huge part of the wealth of the country, and they hold 40% of Australia's net wealth at this stage. And delayed retirement, people are working longer. The generations before us were really proud of the fact they could retire in their 50s. Our generation, not really the case, working on, and we're being encouraged to, as you know from these generational reports and the encouragement of the politicians, that they're looking towards retirement to around 70. Much more consumer oriented, so a lot of technology, travel, online shopping, all of this the baby boomers have embraced. Greater adaptation to change in our generation. The changes have been rapid. We've basically got through that pretty well. Adventurous, various types of holidays and more experiences. Politics has become more conservative as we got older, but basically, as you can see, this is what basically characterised our generation. And yes, people who are older are more likely now to be misusing substances, and it's predicted to double by 2020. Those over the age of 50. One of the this is National Drug and Alcohol Service in 2010. You can see the rates of risky alcohol use and tobacco use. As you can see, it does decline with age, but it's still reasonably high. One of the things about consumption, and this is just about alcohol, is that conceptually there's short and longer term risks associated with alcohol use. As you get older, the short term risks, the amount of binges, reduce. And you can see that quite clearly, the blue bars in that slide. But in fact, chronic risks remain much the same until you're around 70. It doesn't really decline too much. And you say, well, 70, well, you're pretty old by then, but what's the concern? Well, the average person at the age of 70 has got probably 20 odd years to live. That's the concern, is that these days, because of increasing longevity, things that maybe in the past may not have got too fussed about, or it's not going to cause problems in the future, are likely to cause problems in the future, because at these ages people are still living a long time. I'll focus initially on alcohol, then go through some of the other drugs. So as we know, alcohol consumption in older people, there are physiological changes that alter metabolism of alcohol, and less does more. Basically, you get more bang for your buck. And so people who have been drinking for many years will report to you that they're drinking less now than they ever used to. That doesn't necessarily mean they're no longer drinking at a risky level. It just means they're drinking less risky in a total amount sense than they used to. But in fact, for them at that stage of their life, it still might be a risky amount of alcohol. So the amount of alcohol that can cause short-term harm is much less, and but the exact amount less is not really entirely clear. Good empirical research about where harms and benefits might accrue, and there are maybe some benefits we'll talk about in a second, is not very clearly defined in the literature or in experience. In my research area, which is to a large extent looking at dementia and risk factors for dementia and prevention of dementia, and if you've heard of any of the talks that I've been involved with, my colleagues Henry Bedardi, Perminder Sachdev and others, we talk about a low amount of alcohol, red wine perhaps being preventive of dementia. And this is one of the dilemmas, is that perhaps similar, the messages that we give about alcohol in older people are mixed messages. We're not quite sure where, as I said, benefits might be there versus harms. And there are debates as to whether the literature related to increased longevity and lower risk of dementia that accrues to people who regularly drink low amounts of alcohol, whether that's flawed literature or whether that's an accurate representation of what's really happening. And those debates are ongoing. One of the problems with epidemiological studies of dementia is that they usually start at the age of 60. And to get in the studies, you usually have to be reasonably compliant and interested, etc. So are we hiving off a group of people that's not typical of the total population? And are we missing the events that are really happening before the age of 60? So these are largely unanswered questions. Certainly there are aspects of some alcohols, particularly the red wines with the flavonoids, that have some potential benefit in terms of antioxidant type effects on the brain. So there's certainly a rationale there as to why alcohol might be beneficial. And of course, alcohol does have some cardiovascular benefit too. But whether it's to the extent of that benefit related to harms is unclear. So the uncertainty means it's very hard for anybody, particularly in general practice, to give clear messages to your patients. And that becomes a dilemma. In any public health message we ever give, we want a clear message. We want to be able to tell people, look, X, Y, Z. Keep it simple, keep it pertinent. And in this field, it's difficult to actually give that clear X, Y, Z message. And that's a problem that needs to be worked through and resolved. It's certainly true, however, that the less, probably on the less side is better. And in the UK, for example, guidelines have been developed specifically for older people that are a lot less than the general, say, the NHMRC guidelines. So perhaps it's about 25% less per week. So I guess this is one of the areas that's going to be a watch this space, and when better empirical evidence is available that's pertinent to this age group, perhaps you'll get a clearer message to give. About a third of people who misuse alcohol in old age do so for the first time in late life. So this raises sort of various questions from a primary care perspective. You may have a patient that you have no inkling could be misusing alcohol, they never have done before. things start happening. And it's often related to adjustments of life events. Retirement can be one, loss of spouse, depression for other reasons or related to those other concerns, and of course during the early stages of dementia. And it can be hard to identify. Families, children who've never known their parents to misuse alcohol, suddenly become aware there's something happening that's different. So it can be quite a difficult adjustment for them. And it can be a very gradual evolution. One of the things about alcohol use is that daily alcohol use increases with age. So although we get very concerned with higher levels of use in younger people and middle-aged people, in fact it's much more likely that a person over the age of 60 will use alcohol every day than any other age group. And the dilemma, of course, the very relatively safe one or so, maybe 2 drinks a day, that might be reasonable, can easily move into 3 to 4, 4 to 5, without anybody being truly aware that this transition is starting to happen. And of course, those with early dementia will only ever have 1 drink a day. They never forget, never remember the one they just had, and the one they had before that, and the one they had before that. And this is increasingly something we're seeing in our work with dementia. So, in fact, accurate numbers are hard to come by. I remember I still do, but not as much as I used to, in the 80s and 90s, a lot of home visits. And I always said to the community staff, don't worry about the full bottles, just look at the empties in the bin. That's really what you've got to look for. How much they're consuming, not how much they're collecting. The collection doesn't matter, it's not inside them, it's in the empties in the bin. So you're never really sure until you look, until you actually quantify what's happening. So obviously with this group of late onset alcohol users, you've got to deal to a large extent with those precipitants. The issues of comorbidity, it goes to the territory of age. The older you get, the more likely you're going to have comorbidities. And in those with alcohol use disorders that generate their own comorbidities, and then it gets extra complicated. I've got the list there of the various medical problems that alcohol is associated with. And these are really going to start hitting home for people in their 50s and 60s. This is when most of these medical comorbidities start happening. And so once you get to this point, if you've been a long-term user, this is when your comorbidities are starting to happen. And of course, the ones who are developing the alcohol problems in late life may not have alcohol-related comorbidities as much as age-related comorbidities. We did a study, which was just published a few months back, where there's not been much research published about truly old people. One of the because I'm not a substance abuse specialist. I'm an old age psychiatrist specialist. So for me, old is at least 65, maybe 75 is probably more typical. So when I see substance abuse populations where they talk about people at 50 being old, I sort of think, yeah, they're kidding, aren't they? They don't know what old is. But this is an old population. Our mean age of the study was 82. So this is old. This is really a geriatric population. And what we did was we wanted to look at people being treated in any health-related aged care service locally. So they were in rehab ward, geriatric rehab, acute geriatrics, old age mental health, and then in the community arms of those services. We excluded people with dementia purposely because we wanted to get as accurate information as possible. And we also excluded people who were acutely confused, delirious for whatever reason. They could come into the study if they recovered in time to participate. So to start with, you sort of get a sense of a typical geriatric setting. 55% were excluded for these reasons. I mean, that's a fairly standard sort of geriatric setup, is that a lot of people have these cognitive problems or couldn't speak English, but it was mainly cognitive problems. But when people were eligible, 80-odd% participated. So we screened using the standard tools of screening alcohol, Audit C, and we found that 17% were screening positive. and benzodiazepine misuse, there were 4, which was whatever the percentage that is, not very many. 2 were on misusing opiates. So when we talk about the benzodiazepines, that's not how many were using it, that's how many were misusing what was prescribed. In fact, about 25 to 30%, I might have the number later, were actually on benzodiazepines regularly, but only a small number were actually going beyond what they were prescribed. We had a very conservative way of looking at that, and that is we only sort of said if the doctor prescribed it that way, we won't count that as misuse. So as you know, that's from earlier talks, that may not be a very accurate way of looking at it. Polysubstance, nearly all of them were benzodiazepines and alcohol. Now, other than the fact that those who were screened positive for these substances were less likely to be from a non-English speaking background, there were no other ways we could distinguish them in terms of other health and functional factors, or mental health or physical health or functional factors. Basically, the story is that at this point in time, there are so many comorbidities in this population. All of those other sort of comorbidities that might alert you there might be an alcohol problem are just all swallowed up in the mess. The only way you'd know is by asking how much they drank. And I think that's one of the clear take-home messages. In this population, you're only going to know if a person is drinking too much if you ask, are they drinking too much? Pretty simple. We used the assist as well to get all the other drugs. Though none of these people were using any illicit drugs. I don't think we expected to find, or maybe we might get a couple if they're in their early 60s, but didn't expect any of the older ones to be using it. And so after the screening process, we then looked at who actually had a probable disorder. It turned out about 12% of the total survey sample would have had an actual substance use disorder. Now, remember, as I said, we excluded people with dementia. Now, another study that I'm involved with, the Hospital Dementia Services Project, that data from that study and then from other studies I've been involved with subsequent to that, people with dementia have higher rates of alcohol use disorders than people without dementia. Even if, forget about the causation of the dementia, I'm just talking about as comorbidities. So those numbers are underestimating the proportion of people. If we'd included people with dementia, were able to get accurate information, that number would be higher. We looked at the screen positives, and we looked through their files, we talked to the patients, and only 61% had their alcohol history documented in the hospital. Only a fifth had their concerns documented by medical staff, usually only if they had something that seemed to be like they were intoxicated and had a fall. That was about the only sort of way they got detected by the doctors. Of that, only 5, for 14%, had a management plan related to the problem identified. In only 2 was drug and alcohol service asked to see the patient. One of those they were already involved anyway. So you can see, in a teaching hospital in Sydney, very little is being done for these people, very little screening, very little action when screening is done. Benzodiazepine, none were referred for drug and alcohol services. Opioid screen positives, both were referred to the pain clinic. Question is that the best thing for that? In a sense, it might be. There are concerns about how one is managing chronic pain in that population anyway. I think let's talk about alcohol and cognitive disorders. Of course, there is this very complex relationship that exists. So you can have acute cognitive disorders, and as we all know, alcohol withdrawal and various forms of delirium, tremens, and effects of intoxication can acutely disorder cognition, and those cognitive disorders can be quite varied in their presentation: confusion, agitation, behavioural change, psychotic symptoms, etc. And of course, what we need to be aware of is that this is a population at high risk of an acute Wernicke syndrome, and they're a medical emergency, essentially. These people need intravenous thiamine ASAP, like yesterday, not today, immediately. It was a few years ago, not about 3 or 4 years back, the availability of intravenous thiamine sort of disappeared for for a period of months. Nobody knows why, but it did. So in terms of how we manage, these people, this sort of syndrome really needs to be put on, a kind of algorithm flowchart of management, much in the way as you manage acute chest pain or abdominal pain or whatever. Because if you can intervene quickly, you can prevent a huge amount of pathology later. And that pathology becomes a chronic cognitive disorder. So there are a number of chronic cognitive disorders related to alcohol. There's the concept of alcohol-related dementia, which is more or less regarded as a direct neurotoxicity of the alcohol on the brain. Then there's the Wernicke-Korsakoff syndrome, which is the thiamine deficiency component, and which is the long-term effects of that acute Wernicke's that we talked about before. The peak period is 40 to 60. So most people who start their alcohol misuse in their teens, early 20s, it really takes their 40s and 50s for the long-term effects of that misuse to start really affecting cognition. In those who are older, it's more frequently that you're looking at a comorbidity with a primary dementia. Not entirely, but much more frequently. The older you get, the more likelihood is that the alcohol problem is either masking or exacerbating a primary dementia such as Alzheimer's or vascular, occasionally frontotemporal. It's more of a comorbidity complicating management. In the terms of the alcohol causation of these disorders, there's so much complexity there that most of the research these days is suggesting that the overlap between the alcohol neurotoxicity and the alcohol-induced thiamine deficiency is so great that, in fact, you can't truly disentangle. Many of the people who might get an alcohol-related dementia diagnosis have some thiamine deficiency, and some of the people who might otherwise have a Korsakoff type of syndrome diagnosis really have a bit of neurotoxicity too. And then on top of that, many of these people have significant malnutrition, significant history of head injuries, and significant other medical comorbidities, certainly cerebrovascular disease. So these days, the concept of alcohol-related brain damage is really, particularly in the UK, but starting to come into place in Australia, to take over. Another angle about that terminology is that in this population, many of whom, as I pointed out, are somewhat younger than most people with dementia, the term dementia is a no-no word. It's felt to be so stigmatising that people don't want to use that term. And so if we want to engage this population and try to do something to help them, we probably have to change the way we use our language in order to achieve that. So that for all those different reasons, perhaps the alcohol-related brain damage is a better way. The only downside of that, to be aware of, we might have to use dual language in places, is that a number of government support programs require a dementia diagnosis to qualify for the program. So in fact, you might need to use one language for a support program or a Commonwealth service, another language with the patient. But you just need to be aware that these are parts. So there are virtually all, most of these people are going to qualify for dementia-related services. However, they've got to have dementia, and that's a problem. Of course, with these cognitive disorders, there are high rates of challenging behaviours. There's a high rates of injuries. We're just in the process of looking at some data on that, and the injury comorbidity is incredibly high. Community management is often very difficult because of the ongoing misuse of alcohol, and that many people, particularly those with chronic long-term alcohol misuse, don't actually get a diagnosis related to their brain damage until they hit a residential facility. And we've seen that quite a few times. And of course, very few residential aged care facilities are suited for this population. these are younger males mixing in with older females in general, and younger males who don't want to be there, who have a propensity, high impulsivity, high risk of aggression. It's not a good mix. And so this is a problem that's if you talk to most services that deal with people with dementia-related challenging behaviours, most services, at least one person, a male with alcohol-related brain damage who just doesn't fit anywhere. And this is a long-standing problem. So now move on to the non-medical pharmaceutical use area. And so the definition of that is sharing medication. So in our population, we often see the carer using the person they're caring for's psychotropic drugs. So that's often where the sharing comes in an older population. It's different in other populations. Using higher doses, so they use the double the dose that they've been asked to, or for longer durations. Mainly we're talking about benzodiazepines and opioids. This is data from Australia, and you can see the trends, historical trends, and you can see the 60 plus is in yellow, and the trends are basically upwards. I'm not too sure of the reason, I've never really inquired. For some reason, 1998 had some atypical responses, as you can see across the board. But basically, you can see, other than 1998, basically since 1995, for that 15-year period, it's increased in the 40 plus. Basic recommendation, of course, is to avoid benzodiazepines as far as possible in older people. And we've heard all about the various risks, and I won't go over that in any detail. Why are older people on these drugs? Well, first, probably the most common is sleep. And quite frankly, many people are being treated for normal sleep. Biggest problem is people not being prepared or not understanding that their changing sleep pattern is a normal age-related change, and they want to be treated for normal age-related changes. And so that becomes a dilemma. Of other factors, of course, can be that people are discomfort and pain keeps them awake at night, and of course they could have a sleep disorder of some form. But that's the first. The second big problem, of course, is anxiety and stress. So we've got some people who have been on these drugs for years and just continue on. Others who are presenting with an acute anxiety may be appropriately treated for a short-term acute anxiety problem, a few days, but it becomes chronic. So in other words, we have patterns of prescribing that are not the best way to go to treat anxiety disorders. As we heard earlier, really non-pharmacological therapies are the best way to treat anxiety disorders. But you can use short-term, few days to a week or whatever, short-term benzodiazepine to control the problem whilst you get other things in place. There's a debate or uncertainty at present about what benzodiazepines do to your cognition. It's very clear-cut that chronic consumption of benzodiazepines will cause your cognition to be worse than if you aren't taking it. And we certainly have looked at that in mild cognitive impairment, where in our study, Sydney Memory and Ageing study, where we've looked at over 1,000 people, older people between 70 and 90, and looked at their, I wasn't sure if I had a slide either about it, but we followed them up, we've been following them up for 8 years now, and people on benzodiazepines do perform much worse on neuropsychology testing than people who are not on benzodiazepines. There's no doubt about that. That's been shown in repeated studies. The current question that's unresolved is, does a benzodiazepine use actually increase your risk of dementia? And there are a few studies that show an association, but they're not convincing in terms of etiology, because a lot of dementing problems, of course, in their early phases, in their prodromes, will have non-cognitive symptoms such as mild anxiety, mood changes. So it's hard to disentangle whether people are being prescribed these drugs for those non-cognitive symptoms of a dementia that's already evolving versus whether or not the actual prescription itself is actually a causal factor. My guess is it's the former rather than the latter, but it's still a watch this space situation. In terms of illicit drug use, as you can see by this, that as you get older, use of illicit drugs drops off quite rapidly these days. But is that going to be the case in the future? And that's really the unanswered question. The suggestion is no. In fact, that it's going to become more common for people to, over the age of 60, to be using illicit drugs. We've already got some data to support that. Certainly trends in the this is Australia. Trends in Australia suggest that might be happening, but only very slowly. This is in the United States. You can see how this is for heroin. This is over between 95 and 2010. You can see how the older heroin users have been increasing. In general, with the opioids, of course, it's still prescription opioids rather than illicit opioids in older people in Australia. One of the factors to be aware of is that in contrast to the United States, I must say, opioid deaths in Australia are mainly prescription opioids, and they're peaking in people in their 40s and 50s at the moment. So these are people, generally speaking, being prescribed opioids for chronic pain. And so this is, I guess, a bit of a dilemma. There's not that much, and I'm not aware of any. I've only treated one patient so far who's on methadone for long-standing opioid misuse. But in the United States, it's a little bit more common. And so the sort of factors they've identified that are associated with this is certainly, for people on chronic opioids, usually prescription opioids, increased levels of pain and depression, and they're the main sort of factors. Cannabis, as you can see, again, this is the American data, increasing. Again, it's a generational effect. This is baby boomers getting there. In terms of long-term effects of chronic use of cannabis, Wayne Hall last year summarised the studies in this way. As you can see, there are many adverse health outcomes associated with chronic use of cannabis, some of which are more questionable than others. Fact is that there aren't many long-term positive effects. What we don't know is what people are going to be like if they've been using these drugs for 30 or 40 years, which will be what's going to, I guess, happen when we start seeing the baby boom generation truly into their 60s and 70s, if they keep using. And that's the fact is that a lot of them are still using. Not as many have dropped off of using the drugs as one had previously thought. So it's watch this space. We don't know. Big area that I'm particularly interested in is the cognitive impairment area. And in that regard, there are mixed studies as to what might be happening. There is certainly some data that might suggest protection from cognitive disorders, and other data that suggests that it might be harmful. Dilemma, of course, is most of these studies were not really set up for that question. And so we don't know one way or the other. So unclear, from a psychiatric perspective, there is a relationship from the United States data of long-term cannabis use and late life depression. Certainly what that relationship might be, whether it's early life depression carried through, which is probably the most likely thing, it's a bit unclear. So, as I was just coming back to the cognition side, there was one study in the ECA study, in the the data was collected in the 80s, reported in the 90s, secondary analyses, and they found no effects on the mini mental state examination in that study. But again, MMSE is not the best tool to use for that, and it wasn't really set up for that question. So it's, as I said, the cognitive side is an open question, and that perhaps going to need further research. It's something that we need to be aware of, that we just don't know what's going to happen in this space. In terms of cocaine, not a big issue in Australia, but a much bigger issue in the States. Again, you can see the same trend in the States. Whether it's the same trend in Australia, I guess I don't know. This, I enjoyed this report in the New Jersey Record that I got off the net. LD residents at a senior citizens' home were using cocaine and running a prostitution ring. 75-year-old man was providing prostitutes to his younger neighbours. 66-year-old woman had crack cocaine and drug paraphernalia in her home in this, when she was arrested. You know, I don't know if we're going to be having too many of those kind of scenarios, but again, in the States, there's again the same trend is being noticed, increasing age of the people using these drugs. And of course, cocaine has enormous health effects, as most of those of you in the rock and roll, again, baby boomer generation. John Entwistle died of a heart attack whilst on cocaine. I mean, so a lot of these drugs, if people continue to use them into late life, what we're going to see is increasing accentuated medical comorbidities, and that's really going to be the challenge for many of these substances that I'm talking about. Is though the survivors are going to be prematurely aging and have more medical and psychiatric comorbidity. I don't know how likely it is we're going to have many people take up cocaine or amphetamines or any other drugs for the first time in late life. I'm not sure if that is going to happen very often. But certainly those who are using these drugs, who have been using these drugs for many years, this will be a different story. And of course there's some evidence that cocaine may in fact lead to cognitive disorders too. So one of the big, in general, one of the take-home messages I hope you might get from the talk is that as we get this generation of survivors in the baby boomers who've been using drugs for a long time getting into late life, they're bringing with them issues that we don't know what will happen with them. We don't know what 30 or 40 years of use of various substances actually does to your brain. And that's something that we're going to find out. We looked at this in a way in a study that's in press currently. And we looked at people aged 50 and over attending drug and alcohol services in southeast Sydney. And looked at 99 people. 64% lived alone. These are socially isolated people. And only 7% were employed, even though they were 50 and over. And of these, 70% were being treated primarily for opiate dependence and 30% primarily for alcohol. Most, though, many were polysubstance users. And as we heard before, they were on benzos, cannabis, some were on amphetamines and cocaine. And this is substance use in the past month to give you a sense of it. So even though they're being treated, many of them are still using. Their health status, as one might expect from a population like this, with a lot of physical health problems. And they're listed there. I won't go through them in detail, just to point out that their medical comorbidities were a significant challenge to the drug and alcohol servers. High rates of head injuries, you notice that 50% head injuries. I think this is the sleeping giant, if you like, of this population. What does repeated head injuries do as you get older? It does enough when you're younger, but in fact the long-term effects of that. I'm involved in the Koori Growing Old Well study, which is the biggest study of ageing in people with Aboriginal background in Sydney and North Coast. And we published only recently data about dementia in that population, aged 60 and over, highest rates in the world. Our Aboriginal people have the highest rates of dementia in the world. The biggest risk factor we found for that was head injury. The Kicker study, the Kimberley study that was published a few years back, slightly smaller but still major dementia study, head injury again comes through as one of the major risk factors of dementia there. So although in that population people talk media of alcohol as being the cause, in fact it's not. Alcohol is not the major cause of dementia in Aboriginal people. The major cause of dementia is the usual ranges of dementia we have in Caucasian and Asian people, Alzheimer's, vascular, and the risk factors of that often brain injury. So in this particular study, again, it is our 99 people who were examined to see what was happening. You can see high rates of depression. 79% scored above cut-offs on depression rating scale. So these are a depressed population. And in cognition, we use two instruments, mini mental state examination and the Addenbrooke's cognitive examination, which is a bit longer. Big difference between those two, besides length, is that the Addenbrooke's picks up frontal impairment, the mini mental state examination doesn't. So when you use the mini mental state examination, only 8% were abnormal. We use the Addenbrooke's, 44% were scoring in dementia range. So this is I didn't say they had dementia, they were functionally impaired at a dementia range. So these are people attending a drug and alcohol clinic, and they were 44% performing in a dementia range of cognition. And this is really part of a huge issue. Now, if they are sober, I mean, I've seen quite a few of these people 2 or 3 months later where their addictions have been helped and they've come off a lot. About half of them remain impaired and half improve. But we're still talking about huge levels of comorbidity, huge levels of impairment. And again, one fellow I saw, I'm pretty sure the main cause of his dementia, he was only 40-something, was traumatic brain injury, rather than his substance misuse. So what does all this mean, how it delivers services? Well, drug and alcohol services have never been really set up to function in the way aged care services do. They've got a different mindset, different approach. So, and that's a problem for older people. They don't quite fit into that mindset too well. We need to take account of the fact that many people are physically and cognitively impaired. Many people feel stigmatised by having a drug or alcohol problem. They don't really want to go and mix with younger people drug and alcohol problems. They don't necessarily see themselves as fitting that mode, even though they might need the same sort of services. So we've got to look at ways of providing outreach. One of the ways we've done it in our local service is that virtually almost by chance, we set up the addiction medicine service for other reasons, set up an outpatient clinic right in the middle of all the other outpatient clinics at Prince of Wales Hospital. The intent had nothing to do with older people. Just after 1 or 2 years of operation, it became clear that nearly everybody who went to it was an older person. And it works for them. They tend the clinics, they're quite reliable. But exactly how you want to do your services clearly needs to be something that you look at in individual ways. It's got to be tailored to your local area. We're certainly going to modify how it's done over the services offered and provided to younger people. But how that's modified, I don't think there's one rule. In Peninsula Service in Melbourne, they have a part of their service which just focuses on older people. That works for them very well. That might not work for everybody else. In our service, we're trying to set up we have set up collaborative models where we provide support and outreach to people with cognitive disorders in particular, with drug and alcohol problems, and they provide some services for us. We meet regularly, and it's kind of a collaborative model. Nobody, it sort of gets past that. It's your problem, or it's everybody's problem type of approach. And of course, it involves general practice as best we can. There are a lot of barriers to treatment that patients offer. And I think the really important thing is that when we did this study and we talked to all of the people who were screened positive, the common theme that came through was the person that could help the most was the GP. That's what they said. If my GP told me I had a problem, I'd believe him. My GP knows what I drink, doesn't think I've got a problem. So I haven't got a problem. So it's back in GP school. These older people trust their GP quite implicitly. And so if they hear from you that there's perhaps a problem here, they are much more likely to do something about it than from a researcher or from a hospital specialist. So that really came through. I mean, it was a very strong message that they gave us, because we, as I said, we sat down and interviewed these people for an hour or so about these things. This was a common theme through that study. We also talked to the other side, the doctors and the allied health in particular, geriatricians in particular, and nurses, and their worries was they didn't know what the definition was, that issue that I mentioned at the beginning. Didn't know how much was too much. And again, they made the point that they felt that in fact they weren't in the best position to help. Perhaps the GP was in a much better position than they were. So they kind of, maybe they could do, I'm pretty sure they could have done more, we saw from some of that data. However, they felt that it'd be better to defer to the GP. So we have here, I guess, a scenario where we've got to work out ways to help general practice to identify and do this better. I don't think we know exactly the best ways yet, but I think it's probably going to, that'll be the future, I think, is working out how we can better do that and work out models of interaction between various specialist services. So there's a lot of future concerns in this as people age. As you know, doubling of the older population in the next 20 years. Not only that, reduction in the number of people around to support that older population. So there's going to be huge changes that for all cross-age related things that we're going to have to be concerned about. But in this area, an area that's not really common, not commonly addressed up to now, which is going to become more common. I guess we've got both the advantage and the disadvantage. The disadvantage, we haven't got much to build on, so there's not much resource there now, but the advantage is perhaps we can develop new models now that will work better in the future. Thank you.